This conference will now be recorded.
Okay, so I'm going to start over again here. We talk a lot about the final rules as they relate to Medicaid waiver, but we haven't spent a lot of time talking about Medicaid waiver in and of itself. What is Medicaid waiver, and why is it important? And if you're at all following the news this week and have been seeing the change in administration, one of the things that we hear being proposed, and again, it's just a proposal at this point, it may or may not go, is changes to Medicaid and specifically to programs like Waiver and what we may be looking at in the future over the next 4 years or extended periods of time, uh, looks like we may see a change in the way waiver is funded. And it, if the Republican administration gets their way, there may be a decrease in that funding for programs that are under the waiver. So today we're going to talk about what waiver is, what the requirements are for it are, and then we're going to go specifically at the end. We're going to talk about what are Medicaid waiver services. There are a whole series of them. We know them in terms of what we provide. So if you're a residential provider, you know that Medicaid waiver final rule pertains to your residential services. If you're a day program provider, you know it provides you. But there's a whole bunch of other services that the waiver also applies to. And right off the bat, and we're going to talk about this some more in a few minutes. Waiver is a federal program. It's under the Department of Medicaid and Medicare Services, and it
Hey,
is the federal government.
there's a little bit of feedback somebody has there.
Okay, let's see. I can turn it off at my end. Okay, I got it. Is that better?
There you go. You're good. It
Okay.
sounded like
Uh,
white noise over you, but you're
yeah,
good.
yeah. I found out who there was. One person had their mic on. So here we go. Okay, the waiver is an alternative um, for individuals who would otherwise require care in an institution. Medicaid or Medi-Cal in California. We have to do things differently. In 49 states, in the District of Columbia, it's called Medicaid. In California, we call it Medi-Cal. There is an agreement under Section 50 or 1915C. So for those of you who are, like regulations and like to, know all the numbers and all that stuff, in the federal regulations, the waiver that California has is under what's called 1915C, with the Centers for Medicaid and Medicaid Services, allows for waiver services to be offered in either home or community settings. The services offered under the waiver must cost no more than the alternative institutional care. So one of the things that the feds put in there right from the very get-go was, hey, if you're going to provide community services, those services can't cost more than what the institution costs. Well, in almost every case, the institution was more expensive. Towards the end there, as we really started working on bringing people out of the developmental centers, um, and those centers had certain fixed costs. They had costs to maintain the buildings, for the superintendent, for the security, for all these other folks. The cost per resident for the developmental center kept going up, and it was like 100,000. Then it was a few years later, it was 200. It got over $300,000 a year to have somebody in the developmental center towards the end of the time that we really use that as a primary source for providing care for individuals. Now, as many of you know, the developmental centers work for some really specialized settings, primarily forensic, some very serious medical, some other things, but it's very different today than it was 15 years ago. Um, Recipients of home and community-based waiver services or waiver in general must have full scope Medi-Cal eligibility. So if you've got like a Medi-Cal that has share of cost, you're not eligible for the waiver program. Um, and you have full access to services approved under California's plan. So California has submitted its 1915C plan, and that was accepted by the federal government. California has, on occasion, asked the federal government to modify the plan. In 2000, when the pandemic first came onto our shore, there was some changes under 1915K, a different section of the waiver program that allowed for some modifications of the program, some of the stuff that we were doing, remotely, some of the other changes that we did for a while there, and some of the services that were provided and were modified. But the California's plan, the current plan, which is a 4-year plan, was submitted in 2023 and goes till 2027. So right now we're working under a plan that California was approved by the federal government in 2023. Now, what can happen is that states can ask the federal government to increase the number of persons eligible for a waiver. Now, when I worked at Regional Center, and I believe it's still the case, every year Regional Center's got a quota. Okay, you've got to add this many new individuals. So as the population of the Regional Center grows, the number of people that the waiver takes on also grows. So we are seeing a larger population every year. Also, one of the things that California has historically done is it has put more individuals on the waiver than the federal government has agreed to reimburse. And that's kind of a tricky way of they call it maximizing federal participation, which means getting as much federal money as we possibly can. And how they do that is if, let's say, California has 300,000 people out of the 500,000 clients that we serve eligible for the waiver program, we'll sign up 320,000, let's say. And then what will happen is in any given month, they'll go through the computer system and they'll see which of the 300,000 were the most, had the greatest cost. And those will be the ones that they bill. And so for those 20,000 that either had no purchase of services that month or very limited purchases of services, they'll still be on the waiver, but they won't be billed in that month. So they're only allowed to bill up to a certain level, and that's what they do. The waiver program, as we'll talk about a little later, is a voluntary program. So states can be on it, they can not be on it, they can ask for a certain cap, and the federal government will work with the states on their cap. California and some other of the blue states have tended to try to maximize the number of people that they get on the waiver. Other states do not. I was in Nevada a while ago, and I was watching the evening news, and they were showing a family that was on the waiting list, adult individual in the family who had a developmental disability and was waiting for a available slot in the waiver program. And we'll talk about this a little bit more too. And because that state had capped it, because depending on the state's economic situation, uh, reimbursement from the federal government for waiver dollars for the cost of that purchase of services runs anywhere from about 50 to 75%. Now, California being what is considered to be a richer state, we get a 50 cents on a dollar reimbursement. So if somebody is a client under the waiver and they're going to your program, they're living in your residential facility, that means the federal government is paying 50 cents on a dollar of the cost for that person's care. In, let's say, I don't know, Mississippi, I'm just using it as an example, the federal government might be paying 75 cents on a dollar because economically it's a much poorer state than is California. So it varies from state to state. California has historically sent more money in federal income tax to the federal government than California has gotten back in services. So for the last 2 or 3 administrations up in California, so the governor's office on down, there has been a real strong emphasis on let's make sure California gets its share of money that we're sending up to Washington. So there has been a real strong emphasis on maximizing the amount of federal dollars that we bring into California. Like I said, that may be changing now that we have the new administration. There's some talk about maybe going to what's called a block grant. A block grant is where states get a specific dollar amount. And okay, in 2023, let's say you got $4 billion from the federal government for a waiver. Now we're going to give you 80% of that, and you got to live with that. So what would that be? 4 times 20. So it would take out about 80 million dollars from California over the year in terms of how much funding California would get for waiver. So we'll have to stay tuned. I don't have a crystal ball. I don't want to make predictions. I don't want to get political, but these are changes that are being talked about. And finally, the services have to be offered, long-term services and supports in the most integrated setting of the client's choice. So that's in the basic waiver services. Even before you get to the home and community-based part of the service and the final rules, you have to make sure that the services are integrated. Now, regional centers and home and community-based waiver services, again, the Center for Medicaid Services and Medicare Services, regional centers are responsible for ensuring that eligible consumers who want to participate on the waiver are enrolled. Service providers meet the qualifications, so that the regional center has to make sure that you meet the qualifications for waiver, and that individual program plans are developed and monitored. Consumers' health and welfare is addressed and monitored, and financial accountability is assured. So the feds put say, okay, so regional center, you're basically the middleman in all this. Your job is to make sure that these dollars that we're giving out go to someone who wants them, in terms of a program that can do what it says it's supposed to be able to do, that there's a program plan specifically addressing what's going on, and that you're monitoring to make sure that people's health and safety. Now, we all have to deal with the dreaded SIR, or what's the term that they use, these days. But anyways, and that's part of this federal requirement, tracking and analyzing trends, and so the state actually has a contract with an outside organization which helps provide tools and training and technical support for the regional center. And every regional center is supposed to have risk management meetings to make sure that they're reviewing the risks. The federal government says, hey, if we're paying for this, we want to make sure that people are safe in the services, and then they need to be reports that come back. The term that is often used is closing the loop, which means kind of like, we sometimes talk about, closing the barn door after the horse got out. In this case, if we did have an injury or an accident or something that an illness that required hospitalization, that required a special incident, GRE, that was the term that I was thinking of before. If we have an SIR/GRE that we have to send to the regional center, the regional center is supposed to then take a look at that and try to figure out ways to make sure that that person's followed up on and they get the services and supports necessary to make whole again to the best possible that they can. And B, how do we make sure that that doesn't happen again? Is there something that we need to do specific to that facility, to that group home, that will help to make sure that that particular event doesn't happen again? Let's say there was a trip and fall, and that provider had throw rugs throughout the facility, and the client just slipped on a rug that wasn't tacked down, and that was what did it. So maybe going back out to that home and talking with that provider about, wait a minute, these are not safe. We need to come up with a better way to do what you're doing in your home. So sometimes the SIR team will come up with suggestions specific to the facility. Sometimes they're looking at, let's say, maybe within within the community, there's some sort of a respiratory infection that's going around. And maybe there's some a directive that the regional center may send out to group homes and to residential facilities and to day activity and vocational services, saying, hey, you need to be looking out for this. These are ways you can prevent it, et cetera. Some public health things. So the federal government not only requires that regional centers make all these assurances that the person wants to be in it, that the providers are qualified, that there's a plan, and that health and safety is addressed. They also want to know that if there is a problem, that's being addressed as well. HCBS waiver enables states to expand Medi-Cal financial eligibility and other benefits targeted to a specific population. Now, California has something like 7 waivers. So the IDD waiver is probably the largest of the waivers. But there is one for elderly. There's a mental health waiver. There's a one for HIV. There's a few other waivers that California has that provide services for other supports, which then brings in the federal dollars. And it allows states to limit how many people are served. Caps on HCBS waiver enrollment results in waiting lists when the number of people seeking HCBS exceeds the number of waiver slots available. And this is what I was talking about. Nationwide, so if you go across the whole country, there are about 700,000 people waiting to get into waiver programs. And it varies depending on states. Texas and Florida have probably about 75% of the individuals who are awaiting services. So they're large states, more conservative, keep their cap lower, where more some other states, California, New York, tend to have much more generous programs. So it is state specific. States have a right to decide what they want to do. Every state offers at least one HCBS waiver targeted to one or more populations. So every state has a home and community-based waiver type program. And again, seniors, seniors and adults with physical disabilities, medically fragile, technically dependent children. California has a waiver for that as well. HIV/AIDS, mental health, and then traumatic brain injury and spinal cord injury programs. So those are all waiver programs that are out there at the federal level, and states can then choose if they want to sign on to that. Again, depending on the state's financial situation, it can be anywhere from a 50 to 75% reimbursement for the services they provide. So in many states, they allocate, okay, we're going to have, let's say, 20,000 slots under our medically fragile and dependent, technologically dependent children's program. So as children come through who maybe are ventilator dependent, tube fed, other very serious physical needs, and we want to keep them at home with potential nursing care and other services, this is how many that we'll support in our state. If there are more children, then maybe those children might have to go into institutional care, or maybe that family won't get the additional support necessary. Nationally, there are a total of 287 HCBS waivers, including those under 1915C and those under Section 1115 across all 50 states and District of Columbia in 2017. That was the most recent numbers I could find. So that's about 7 years old. But at that time, of the 50 states, there were 287 waivers. And again, the largest group of waivers tend to go towards persons who have a developmental disability. I remember when I was the director of clinical services, and we would meet quarterly as a group with the Department of Developmental Services. And we walk into this one meeting, and the state people said, "Oh, we have this new program that we're going to be starting. Going to be a real small little program. Going to really not, you won't see any difference at all. It won't make any changes to the way you do your services. Very transparent, but we can get some federal dollars." And what started off as a very small program is now, 40-some% of the DDS budget. So, almost half of DDS's budget for purchase of service comes from this program. And like I say, California gets other programs. Interesting enough, the feds will only deal with one agency in every state. So in California, when you have services that are for seniors, and then you have technologically dependent children, and you have persons with developmental disability, and you have mental health, there are a number of different agencies there. And the Fed says, no, we won't do that. So the Department of Health and Human Services here in California, the DHS, does all the billing, and the feds only work with them. So it's interesting because DDS doesn't really get the money. So DDS, it gathers all the information, sends it over to Health and Human Services up in Sacramento, across the street, and then they bill the federal government along with the bills for the senior program, along with the bills for California Children's Services, for the behavioral health services, et cetera. So and then the money just then goes into the state general fund, and it's then distributed back out to developmental services. So it's not like when you provide a services, it's being directly billed. It goes through a whole process of how that then becomes billed. In order for an individual to be determined to need waiver services, an individual must require the provision of at least one waiver services as documented in the service plan. So they have to need at least one service that qualifies under the waiver. The provision of waiver services at least monthly, or the need for services is less than monthly, the participant requires regular monthly monitoring, which must be documented in the service plan, specifically the state policy concerning the reasonable indication of needs for services. So you can tell this is federal language. This is, I didn't write this, but they basically are saying, hey, you got to be, you got to be eligible for a waiver service and needed that service at least once a month, and it has to be monitored. In order for an individual to be determined the need waiver, an individual must require the provision of at least one waiver services as documented in the service plan, and the provision of the waiver service at least, okay, whoops, that got repeated. Okay, sorry about that. This is just for your information. In 2017, the number of people who were waiting for waiver services throughout the country. So this is the whole United States, and at that time there was about 700,000 people. And look at you, so you can see the largest majority of individuals who were awaiting services were developmentally disabled, with seniors and adults with physical disabilities being the second largest group, and then others were 5%. Now, interesting enough, because we have the Lanterman Act here in California, and the Lanterman Act basically is an entitlement. There was a Supreme Court case, which I've talked about before. It was ARC versus DDS. So the ARC in San Diego started the case, and then the state ARC took on the case. And if you're interested, you can look that up. It's a pretty monumental case. But basically, what that case said was that it was the intent of the legislature that services be an entitlement for people with developmental disabilities. So if it gets written into an IPP, the regional center has to provide it. Or if it's something that can be done generically, the regional center has to help that person to find it somewhere else. So everyone gets services in California. Guess what? No other state has an entitlement. That is just uniquely a California situation. So anybody who walks in the door of a regional center who is 5 and older, under 5, they go into the early start program, which has got different set of rules. But if they're 5 and older and they're eligible for regional center, what gets written into that plan is what the regional center has to provide. So someone can get services in California whether they're waiver eligible or not. Now, it's to California's advantage if someone meets the eligibility criteria for waiver to get them on waiver, because then they can get the federal government to pay for 50 cents on every dollar of the cost of that service. But California, it doesn't matter. If they're not eligible for waiver, we'll still fund them. One of the issues that's going to be potentially controversial in the near future, and again, I don't want to be political, but California serves individuals regardless of their documentation. And so individuals who are do not have documentation to be in this country still receive services. But clearly, those individuals wouldn't be eligible to be under the waiver program, because the waiver program says you got to be eligible for full-scale Medi-Cal, and you can't be eligible for full-scale Medi-Cal if you're not a resident. I mean, California has got some provisions now to provide some Medi-Cal to persons who are undocumented, but still, historically, those individuals have not been, but they still get the full array of services in California currently. Will that change over time? The other thing to keep in mind too is that the Supreme Court decision, which said that services are an entitlement in California, said it was the intent of the legislature when they passed the Lanterman Act to make it an entitlement. Well, what does intent mean? It means that that's what they wanted. Well, what if the legislature decides next year, 2 years, 5 years from now, that they no longer want to do that? They can go back and say, well, we don't have the funds necessary. We don't, our commitment to persons with developmental disabilities is changing over time, and we want to do it this way rather than the way we've historically done it. So the legislature could intend to do it a different way in the future. But for right now, it's transparent in California. Whether you're on the waiver or not on the waiver, you still get the same service mix if that's what's in your plan. In other states, if you're not on the waiver, you may not even be receiving services, or you'll receive minimal services from state programs because the state relies almost entirely on the waiver dollars, the 50 to 75 cents on a dollar that they receive from the federal government to pay for the services for developmental disabilities. So it's variable depending on the state. And like I said, many states do have sizable waiting lists. Final rules. So this is where we start getting into the changes that came about in 2014. So there was a period of time that the federal government said, okay, we want to make some changes to the Medicaid system, the money that we're putting into states. And we want to make sure we do this consistent with some federal legislation that's out there. There was the Americans with Disabilities Act, which had some very specific requirements about accessibility and the ability to be able to be fully integrated. There was also a Supreme Court decision, the Onset decision, which basically said you can't use funding. So you can say, well, it's less expensive, or this is the way we as a state want to provide the services to justify keeping somebody in an institution or a segregated setting. So the federal government was under some guidance and direction to really come up with a new set of rules. Those rules went out to public comment. And this was back probably at about 2012, 13, early 14. And in March of 2014, the final rule came out. So what we are now working with and how we are providing our service models to the individuals that we serve come from these rules that were generated in 2014. As many of you know, they were originally supposed to go into effect in 2019, a 5-year phase-in period, when President Trump was elected the first time around. His Health and Human Services Secretary postponed it to 2021. Then COVID hit in 2020, and then they postponed it to 2023. So it actually was, from what was originally 5 years, it became 9 years, and then California asked for an extension, and it then went to 2024. But we're fully in place now. So California has submitted its plan for correction, and the plan is being reviewed as we speak by the federal government, and hopefully everything will be fine. Settings where individuals live and receive services must be about the nature and quality of individuals' experience, rather than the type of buildings where the services are delivered. Big change. Years ago, when I was first starting, what was the issue? We wanted clean, nice, airy, well-lit places where people could go. Clean bathrooms. We'd all seen the horror stories of what had happened at the institutions, the old the Geraldo Rivera doing the expose on Willowbrook in New York, and other things where people were dehumanized and really badly treated. So what became the norm was, let's make places and buildings that are nice, that are, you walk in, it's clean, it doesn't smell like urine, it doesn't it you know it's a comfortable place to be. There are nice chairs for the individuals to sit in. There's like I said, it's airy, it's got good lighting, it's clean, floors are clean. That was the focus. And a lot of licensing. If you go back and look at what does licensing look at? They look at, what's the temperature in the room? Where do you keep your stuff, your supplies? Do you have this on hand? Do you have that? So we were really looking at the type of building. So your home, your day program. What did they look like? Did they meet certain standards? Now what they're talking about is it's about the services, the nature, the quality of the individual's experience. That is really where the concern is. So it was a shift from, let's talk about physical plant and making sure people are safe, to let's talk about what sort of experience people have in their lives and how that benefits them. And we wanted to really ensure the quality of service. That historically we were looking at, again, not as much of the was services being provided, but were they quality services? Were they meaningful? Did they really have some movement forward in that person's life? So that became a part of the standard as well. Setting standards that services and supports where they are provided must meet to be eligible for reimbursement under Medicaid. So California always had licensing, and California did a pretty good job since probably the late 60s, early 1970s in making sure that providers met standards. And the whole vendorization process, where you submitted your program design, and Regional Center came out and did quality assurance reviews of your program, meant that California was in pretty good shape when it came to this standard. Other states, it varied all over the map. So the feds came in and said, okay, we're going to make this a requirement for everybody, that you have to make sure that the programs that are going to be reimbursed with federal dollars meet certain standards. And that's part of the plan that California has to submit, as well as every other state, of how you're going to do that. That was an easy part, I think, for California, because we were pretty much there already. Establish ongoing monitoring and quality assurance processes that will ensure that all settings providing HCBS continue to remain fully compliant with the rules in the future. So that's what we're going to be looking forward to. This last year, we came out, both the Regional Center and then myself as part of a group from Positive Purposes, to your facility and used a certain standard that the state had developed to look to make sure that you were meeting the either 5 rules if you were a day program, 10 rules if you were residential. But now regional centers are going to have to yearly, or whenever they're doing their quality assurance review of your program, making sure that they continually are monitoring to make sure that those guidelines are met. It wasn't a one and done where we came out, okay, you're in compliance now, all is right with the world, see you, adios, see you later. We're going to be back, and when we come back again, we're going to be looking once again to make sure that you're continuing to follow these sets of rules. So that's again a federal requirement. This is what I was talking about a minute ago, the Americans with Disabilities Act, and then the Olmstead decision require integrated settings. And California has not been sued, but the federal government has sued a number of states, saying, "Hey, segregated programming." So they've gone after adult day programs and certain types of residential settings, saying these are segregated. These are they're not part of the general community. They're entities onto themselves, and that's not provided. So I know, for example, Oregon signed a consent decree with the federal government a number of years ago to really change, and they've done quite a bit of work to make sure that services and supports that they provide to individuals who are in the Medicaid program are much more integrated. So the most integrated setting is defined as a setting that enables individuals with disabilities to interact with non-disabled persons to the fullest extent possible. Again, that's right out of the federal definition that goes into the HCBS rules. Integrated settings are those that provide individuals with disabilities opportunities to live, work, and receive services in greater communities like individuals without disabilities. Pretty simple. We're moving in that direction. We still have programs that tend to be a little bit more site-based, and residential facilities that primarily provide the services at the home and don't necessarily get a lot of time and opportunity and meaningful interactions in the community. And we need to really continue to focus in this direction of moving people into the greater community with individuals who are not disabled. The advantages are twofold. One is for the individual with the intellectual and developmental disabilities is to be more, to learn and to develop and to utilize the skills that are part of being in the community, and for the individuals in the community to have a greater understanding and so that people are fully included as part of who we are. And then integrated settings are located in mainstream society. So and this became an issue when HCBS was moving forward and the federal government was coming out with some rules. There are some what are called intentional communities where, let's say, a farm that's in a rural area that has is run by an organization, and all the residents or the farmers on the site are persons with disabilities. Now, and that the feds had to really look at that and address that. It doesn't really pertain to us here, but as to how do you consider that to be an integrated setting located in mainstream society? And some of those ended up receiving what's called heightened scrutiny, and there was some challenges on how do you define that and what do you do with that. But again, that's not an issue that we have to address here. Offer access to community activities and opportunities at times frequent that and with people of the individual's choosing. And again, this whole concept of choice, that we give people choices in their lives of where they go, what they do, who they interact with. Afford individuals choice in their daily living activities. What do they do during the day? Do they choose, or do we have a structured program that from 8 to 9 we do this, from 9 to 10 we do this, and not give people an opportunity to make choices about what they do, where they go, who they interact with, etc. And provide individuals with disabilities the opportunity to interact with non-disabled persons to the fullest extent possible. And again, these are all coming right out of the federal regulations. So we've seen the 10 rules, but this is what sort of sits behind the 10 rules that the feds came up with. Um, Segregated settings per ADA and Olmsted. Congregate settings populated exclusively or primarily with individuals with disabilities. So if you have a setting that it doesn't have individuals who are non-disabled in it, and this, some day programs still can fall under this type of a situation. Some residential settings, and this continues to be a challenge on how do we meet this as we move forward. Regimenting in daily activities. So again, that schedule that says we do this from 8 to 9 to 10 to 11. And as if somebody says, well, I prefer not to do that. Well, I'm sorry. If you go to our program, this is where everybody goes from this block of time. A lack of privacy or autonomy. So if clients don't have privacy in terms of their daily living, or their hygiene, their other things, or the ability to make decisions for themselves, limiting visitors. So that, which is a big issue with you see when we were doing the assessments. One of the things that came up was the whole idea of people have a right to visitors at any time. And that was a kind of a challenge for a lot of, especially residential facilities. But it's interesting because you see that in more settings. This last week, I learned that someone that I worked with for many years was hospitalized, and so I called to find out what the visiting hours were, and the hospital said, "Oh, anytime. We don't have visiting hours anymore." And I remember we always used to be like, okay, so you had very specific hours where you could come and visit. And so I think this is going across the board. We're seeing more and more that we don't see visitation limitations. Limits on individuals' ability to engage freely in community activities and to manage their own activities of daily living. So this is again a challenge in many of our programs, because and you always run into the whole issue of funding. And if your program is funded at 1 to 6, so there's one DSP, the direct service professional, for every 6 individuals, and that person has to provide the support and supervision for those 6 individuals. It's a little hard to let everybody do their own activity and engage in what's going on, because you get this double message of give the person their autonomy, freedom, let them go do what they want, but you're also responsible for their supervision, and that can be a challenge. So and it continues to be a concern for many providers of how do I do things, or what can we do as compromises. Some programs sit down weekly with a group and say, okay, so what do people want to do? And they ask the individuals, and they try to integrate the what the 5 or 6 individuals in that group want to do. And so maybe one day they do this, half day they do that, half day they do this. So they're trying to do things that all the group members want to be able to do, and then come up with some compromises, which is what we all do. At times we have to compromise. Settings that provide for daily activities primarily with other individuals' with disabilities. So if it's a setting that provides daily activities, but it's primarily for just other disabled individuals, that doesn't necessarily meet the standard either. The final rules, as we well know, individuals have an opportunity to make an informed choice. Such steps include providing information about benefits of integrated settings. So we need to share with the individuals that we serve that they know, they
Sorry, Jeff.
understand.
We have
Yeah,
another mic on if you want to mute that for me.
what's that?
There's another mic that's on. There's some
Oh, I'll
background.
turn it off. The So that individuals will have the opportunity. So in the first standard, it talks about that clients are given the opportunity for integrated employment, and that's a good example of being allowed to be in an integrated setting. So it really depends on the individual, and again, different folks have different community skill levels and ability to utilize uh, what's out there. And so we really need to assess as part of the planning team for each individual, what does this mean? And how, and for integration for one individual might be different for than individual integration for another individual. And that's really the beauty of the individual planning, is that we look at each individual and what their requirements are. Um, Facilitate visits or other experiences in such settings. And again, many of you have heard me say when I was working at Bakersfield ARC, and we really first looked at our day activity program being 100% community based. And we went to the individuals who we were serving and said, okay, so what do you want to go? Where do you want to, what do you want to do? And, we heard back from many of them, basically, Valley Plaza, Walmart, Dollar Tree, places that maybe the movies or bowling, places that they knew. So, part of what we should be looking at doing is providing people with an opportunity to learn about other places, to new things, to go to places that maybe they haven't been to before. So maybe taking a group one day to the County Museum and spending some time in the area where they have all the neon signs, and some of the older buildings, maybe going out to the uh, White Wolf Preserve, where people can hike on some nature trails. So there's a lot of opportunity in the community, and those are just examples of things that people can do that are different, that they may not have tried before. And then when they come back, you can then ask, so what did you think of that experience? And some folk, I didn't care for that. I don't like hiking. I don't like being out in nature. Somebody else might say, "Oh, no, it's great. I loved it. I want to go out there again, be part of that." And so we want to look at that. Offer opportunities to meet with other individuals with disabilities who are living, working, and receiving services in integrated settings with their families and with community providers. Some of you probably have met with Sam Herrera. He works at Bakersfield ARC, and also works at Walmart. And he does peer support. So he goes out and will talk to groups about what it means to be employed in the community, and give people an opportunity to see firsthand, peer to peer, what it's like. We also have, or Bakersfield ARC has Nicole Mensch, who is living independently in SLS and works part time at Bakersfield ARC. Again, with the same idea of talking about to individuals about what it's like to live in the community with supports, and to be working. So we really want to offer individuals those opportunities to see that. And if you are interested in having either of those two individuals come and talk to a group of the people that you serve talk with Valerie, who is on this call. You can either just put it in the chat, or you can give her a call after this is over at Bakersfield ARC and set up an appointment time, and either one of those two could be available to spend some time with your individuals on doing stuff to help you out. Um, and then you must make reasonable efforts to identify and address any concerns or objections raised by individuals or other relevant decision makers. So, got to have a grievance policy. Got to have an ability to, if clients are share with you dissatisfaction with services or with a staff person or how something happened, got to make them aware that they can share that with you. And that has to be done in such a way that there is no repercussion for the individual that's served. Recently, I learned of a situation where a consumer shared dissatisfaction with something that staff were doing with a family member. And that family member then talked to the administrator. And when that individual then talked to their family member about a week or two later, the individual said, "You got me in a lot of trouble because now the staff are mad at me." So wait a minute. You hear what happened there? It was like, wait a minute. The client shared a concern. Family then shared that with the administrator. Administrator shared that with the staff that were involved. And the staff then sort of retaliated on the consumer, on the individual who was receiving the services. Can't have that. So if somebody makes a complaint, it has to be a whistleblower or any other type of complaint that's made by an individual served. It has to be treated in a respectful manner, and there can be no repercussions for making that. So the staff, they may very well be upset or feel hurt or angry about the individual doing it, but they can't share that. That's not professional, and it's also not consistent with the rules. Okay. Now, in order to be in waiver, there has to be a reasonable objective assessment by a public entity treating professionals. Such assessment must identify individual needs and the services and supports necessary for them to succeed in an integrated setting. So in California, again, that's the regional center that does that. It's different in different states. Some states use a public agency. It could be a county agency, it could be a state agency. California is sort of unique in using nonprofit entities. The regional center system is uniquely California, and so it varies from state to state. Professionals involved in the assessment must be knowledgeable about the range of supports and services available in the community. So the feds say, wait a minute, if you're going to be looking at what somebody needs and helping write the plan, then you need to know what's out there and be able to make sure that the client gets the services that they need. A participant-centered service plan is developed for each participant. All waiver services are furnished pursuant to the IPP. The IPP describes, this is, again, the federal rules that set up waiver say that each individual, their services are driven by their individual plan. The waiver services that are furnished to a participant, their projected frequency, and the type of provider that furnishes each service. Now, historically, plans were sort of vague, that were written by client will attend XYZ day program. client will live at this facility, and didn't really have a lot of specificity. What we will be seeing as we move forward is tends to be more and more specificity and goals and objectives. And as we move into the whole rate model that we are now in, and for this year, if you signed up for the statewide directory, you're getting the 10%. But subsequently, starting in I think July of 2026, the state's developing standards that providers will have to meet to receive that 10% additional service. So one of the ways that the standards will be reviewed is by looking at the individual plans and looking at, wait a minute, if a objective was set that you're going to be implementing this, that you're going to be meeting this goal over the next year, how well did you do? So if you take a group of individuals that you're serving, and you were able to provide services consistent with the plan 30% of the time, you may find that you're not going to be receiving that additional funding. Again, the final version of those standards are not out yet. The state's still working on developing the specific criteria that they will use for each type of service, but they are going to be looking very much on performance based, on how well you as a service provider are able to provide the services to individuals. So again, moving away from the model of, hey, it's clean, it's nice, it's comfortable, it's friendly, to let's look at the service itself and how is that service being developed and is it being met, is really the direction that we're moving. The other services regarding a funding source, including state plan services and informal supports that complement waiver services in meeting the needs of the participant. So one of the other things that the HCBS waiver is going to look at, and there's another slide in a minute here we'll look at, the whole concept of what is oftentimes referred to as generic services. And then generic services are services that are provided by a provider other than the regional center, other regional center dollars. And in most cases, these are services that are available to the general population. So everybody in the community has the ability to utilize this service. Now, one of the main ones that we see for adults that most of you on this phone call are serving is Medi-Cal. Medi-Cal is for medical, so and dental and vision. So if somebody comes to the regional center and says, "Hey, I would like a purchase of service under the waiver program specific to this. I need to get these medical services." First thing regional center is going to say is, "Wait a minute, have you attempted to get those services through Medi-Cal first?" Someone comes to the regional center and says, there's employment issues. They're going to try to have them addressed through Department of Rehabilitation, if possible, mental health services through behavioral health. We're now moving into the whole area of social and recreational services, and some of those can also be provided by parks and recreation departments, especially if you're a residential provider and are not eligible for receiving them through purchase of service funding. And state plan also says these are things that as a state we are committed to doing, and those vary from state to state too. California tends to be more generous in terms of what it puts into its Medi-Cal and Medicaid plan than do some other states. A number of years ago, back in 2008, 2009, when the recession hit, when we had the very serious downturn in our economy. And so the state of California was bringing in less money to the state. So the state budget basically tanked. There were a couple of years there where the state said, okay, Denical, dental services are an optional service. The federal government doesn't require us to, as part of our Medicaid plan to have dental. We as California elected to put that in there. We're going to do away with that for a while. So for a couple of years there, there was no dental benefit in the Medi-Cal program. And now, I'm sort of old-fashioned. I can't sort of understand how the mouth isn't part of the body and isn't part of our health, but it unfortunately became separated from that for a few years. But that would be now that it's back, it is generic service. So if somebody needed extensive dental work or whatever, you would need to go through that. The federal government says you have to go through other sources of funding first. One of the things I always thought was a little, I don't know, never fully understood was Medi-Cal and regional center services are both funded by public dollars. So, when you say, okay, go to some other source first, and that other source is also public dollars, it's like, okay, instead of taking it out of your left pocket, let's take it out of your right pocket. So, I oftentimes looked at what was the best outcome for an individual. So if it was we got a better outcome by using purchase service dollars and by using generic services, I would sort of stretch it a little bit. That flexibility seems to be pretty much gone. I don't, that was years ago, and I think today the use of generic services is pretty rigid in most cases. There is some exception in the Lanterman Act. So, for example, if it takes more than 60 days to get a service from that generic resource, so like something is under Medi-Cal appeal. Or somebody is trying to get, let's say, for example, a child is trying to get behavioral services for a child who's on the autism spectrum, and the insurance company is sort of doing a pre-authorization and this and that. There are some provisions the regional center can fund for that in the interim, and that's again state of California, maybe not in other states. The service plan is subject to approval by the regional center. So federal financial participation, so that the federal money is not claimed or waiver funds prior to the development of a service plan or for services that are not included in the service plan. So you hear the term sometimes prior authorization. And I'm sure some of you have been frustrated at times because you have the meeting, everybody agrees that the client will be coming to your program, and then you wait and you wait and you get on the portal. You go into the uniform fiscal system of the regional center to see if that authorization, that purchase of service, now exists on the system, and you wait and you wait, and it takes a month, 2 months before it shows up. Well, under these federal rules, until it does show up, the state won't get paid. So that 50 cents on a dollar. So that's why there's the regional center saying, nope, don't start it until you see it on the portal. The other thing too is regional center will oftentimes not, and in most cases, if you say, hey, we need this like right away, emergency, there's some other problem that comes up. Well, we're sorry, that's not in the person's IPP. We can't fund for services per the federal rules unless it's in the plan. So that means we have to reconvene the plan and put it in there, and that takes some time. And so that there in the past, where oftentimes we would use emergency funding and do some things, a lot of that flexibility isn't there, both because of some state rulings and some federal things. So it really does limit, in some ways, the ability to be immediate and flexible in terms of services. Um, federal participation, federal fund participation, is not claimed for services when another third party generic is legally liable and responsible for the provision of payment of services. So, like I said, if Medi-Cal is supposed to be providing it, which Medi-Cal is also a federal program, then you can't get money through Medicaid waiver. A federal provision may also not be claimed for services that are available without charge or as free care to the community. So if it's a service that anybody can get in the community, and then somebody says, okay, we want to bill it to waiver, no, if it's free to everybody else, it's free to people who are on the waiver program. Okay. The state operates a formal comprehensive system to ensure that the waiver meets the assurances of other requirements contained in their application. So the state makes its 1915C application, and they have the feds want to make sure that they've got some way to make sure that they're evaluating their own application. The DDS continues to evaluate to make sure the regional centers are doing what they're supposed to be doing. And that's why you see the regional centers every 2 years get a waiver evaluation. From the department sends down a team to look at that. Through an ongoing process of discovery, remediation, and improvement, the state assures that health and welfare of participants be monitored, the level of care determined. So how much, what type of residential care facility does this person need? What level of supervision, 1 to 2, 1 to 3, 1 to 6, the person might need, that individual plans and services are delivered. One of the things that California monitors very closely is the percentage of IPPs that are current. And if you go down and talk to service coordinators, that's a performance issue for them through their supervisor. If you need to make sure that depending on the frequency of the IPP, which can be anywhere from 1 year to 3 years, depending on the type of setting and the needs of that individual, are they current? And because that's a requirement of the feds. Then the provider's qualifications. Again, there needs to be in a vendor file for each individual. Regional center maintains a vendor file that needs to be current. Some of you are finding now that you're because of the rate study and its implementation, the final parts of the, when they condensed service codes, some of you are now having to switch to a new service code, and or that the description of the service code that you've been in has changed somewhat, and you're having to rewrite some of your program design or rewrite it altogether. I mean, completely write a new one. And that will require the really looking at your qualifications and reviewing all of that again. One of the things through another grant proposal that I'm working on, technical assistance may be available in the near future for those of you who are looking at rewriting your program designs. We're in, a group of us are in negotiations with Regional Center as we speak to maybe start that in the near future. So stay tuned on that. Not a given yet. And then health and welfare. If you've had any IPPs recently utilizing the new format, which went into effect January 1, there's a new statewide format that's kind of a questionnaire thing the regional center service coordinators have on their iPads, and they're coming out and utilizing that. Health and welfare continues to be a major concern, and are people receiving the annual health evaluations? Are both women and men receiving wellness checkups consistent with their age? And as individuals age, are women receiving mammograms, pap smears, other services? Are men receiving prostate exams? Are we making sure that people's health, both when they become sick, are they receiving the health care that they need to become well, but also, even more important, preventative care and checkups and things to make sure that people's health is maintained and is kept optimal is a major thing. Um, um, Feds are really big on financial oversight. And when they come out and do their audits of regional centers, one of the things that they're looking at is, how well the regional center spent the federal dollars. And so they're looking to make sure that, if somebody was somebody attending the program, was that consistent with the plan? And then overall, just the administration of the waiver. They're looking both at the state level and also at the regional center. How well are you utilizing this waiver? Okay, so it's like last 10 minutes, and so I actually did a pretty good job on this one today. So yes, the timing is good. These are what services California has in its waiver plan. So if you were to go onto the website and go to the DDS website and go into the Medicaid waiver section and then click on the 1915C plan, there would be descriptions on all of these services and this is what makes up California's waiver. So many of you know waiver because you're a residential provider. And so, okay, your service coordinator told you, 3 out of the 4 people who live here are on the waiver program. So we have to make sure that the goals and objectives that we set and this and that, and we have to do this. And you have to make sure that you meet the 10 goals of the plan. Some of you who are day providers, same sort of thing. You have to make sure you make the 5, and these are the clients who are on waiver. Although California says it's transparent, we really shouldn't matter whether somebody's on waiver or not. Services are the services. But anyways, so there are the next 4 slides. Actually, there's quite a bit of services that actually do fall under the California waiver plan. So any of these services that meet these the service codes that are consistent with these services are billable to the federal government at, like I say, 50 cents on a dollar for California. And those community living arrangement services, so most of your residential services, your small family care homes, group homes, the specialized homes, etc., supported living services, so for those consumers living in their own apartment or receiving supports, day services, pretty self-explanatory, respite, both in-home and out-of-home. So for individuals living in their family home who have somebody come into their home, or if they go to a residential facility, pre-vocational services, so services trying to assist somebody so that they can get the skills necessary to be able to work. Home health aid, so for some clients who are receiving really something greater than respite, so maybe health with care and supervision, or self-care, minor medical issues, homemaker services, work activity programs, supported employment groups. So clients who go out into the community and are working as a group. Interesting enough, the old rules used to be that it was supposed to be 1 to 3. Now, under the new rate setting model that's coming, that went into effect January 1, it could be 2, 3, 4, 5, 6. So more flexibility on the size of employment work groups. Rate is adjusted accordingly, obviously. So the fewer people, the higher the rate, the more people, the lower rate per person. Um, Family support services, uh, speech, hearing, and language services. Again, you got to go to Medi-Cal or private insurance first, and if those weren't available, again, dental services, all these medical services have to be, generic services have to be looked at first. Uh, Optometric optician services, psychological services, occupational therapy, physical therapy, family consumer training. I'm not even sure what that is, but um, choice services, um, community based adult services, community based training services, community aids, environmental access adaptation. So if somebody needs a ramp or some other modification in their home, grab bars, other things, overhead uh, movement type device, fiscal management services. So for those clients who are in self-determination, who or buying services independently, somebody who can manage the payroll and all of the stuff related to federal taxes, etc. Uh, Non-medical transportation, uh, nutritional consult, um, personal emergency response systems. So, like one of those, you see those commercials, "Help! I've fallen and I can't get up." Those type of programs for homes or for community. If somebody needs a monitor to do that, uh, some skilled nursing. So, somebody needs nursing in their home. Specialized medical equipment and supplies can be billed to the waiver. Transition setup expenses, so somebody's moving into a different type of settings. Vehicle modifications and adaptations, so usually that pertains to potentially putting a lift into a van, but it could also be steering devices or other modifications that might be necessary. Housing access services, so making sure that people have access to their home, coordinated family supports, and participant directed services. So there's a large series of services that fall under California's waiver plans. You can see there's 4 pages of it. That's okay. It's 11:30. Any questions?
I don't have any questions, Jeff, but I do want to say thank you for that valuable information and glad that you touched on that subject.
Yes, Jeff, thank you for the presentation. Great information.
Okay, so hopefully that was helpful. I'm really looking at, giving you a little bit of background information. The one thing I didn't share with you today, but some of you have probably heard this before, the waiver came out of a young lady by the name of Ketty Beckett, who was ventilator dependent and whose family wanted her to be at home. She was in institutional care and costing a very large amount of money, a young child. And mom wrote to that time President Reagan, and Reagan said, "This doesn't make sense. Why can't this child be with her family at home, and especially if it costs less or equal to what it costs to be in an institution?" So that's how the waiver started, and that's why they call it waiver. Is that it's waiving the rules. We are now at the point where there are not a whole lot of people left in the institution, that almost everybody lives in the community. So, there's some of us who say that they ought to change it and call this home and community based services and have the waiver be for those people who need to have institutional care. But the language hasn't changed. So we still call these services waiver services, but the waiver is not what it is anymore. Well, okay, with that, I'll entertain any one last question. Any Going once?
I just want to make sure that we do give a reminder that next week the community of practice
Yeah,
originally that was for last week we
right.
postponed it to this coming week.
Yeah, I had to postpone last week. So if there's a 1 hour course that'll be more on specific to the HCBS practice issues. So if you're
Yeah,
interested in that,
I
that'll be
wanted
next week.
I
Um,
wanted to just give the opportunity because we did have a good turnout today.
okay, yeah,
All
and you know what and you know what I forgot when I first started to put up the slide. But if you want continuing education credit, you need to make sure that Valerie is aware that you're on this morning. You need to. I noticed in one case there are two of you on there. Make sure she has both names. And then you need to send in to Valerie a list of at least 3 items that you learned today from this. Could be it doesn't have to be a novel, could be just bullet points, but we want to make sure that you did stay on for the whole presentation. And we respectfully request that you submit it within 30 days to us so that we make sure we get it. So you send it to Valerie over at Bakersfield ARC. She had put up her email a few minutes ago in the
chat.
chat. So yeah, please send her your request for continuing ed, and along with the 3 items that you learned today, and we will get you out something that meets both Kern Regional Center and community care licensing standards for continuing education.
And
Thank you
then
for your time.
I would also just really quick want to mention again, like Jeff said earlier, if anyone's interested in having Nicole come out and speak to the consumers that you provide services to, she'd be more than happy and willing to do that. We do have some coming up scheduled this coming month coming up. So if you want to be put on that list, please keep in touch. I did put my email there in the chat. And then also take advantage if you did see the notification come in of the Relias training. If you have any questions at all, you can call me here at the office anytime, and I can answer those or send me an email. No problem.
Yep. And just for those of you who may not know what that is, Relias is a national company that does training for a number of different areas. They do mental health, they do seniors, they do IDD, they do corporate training, and we contracted with them under this grant, and they've given us about 30 classes that you can self-direct. You can take it at your own time. And when you're so if you want to do it in the evening or on a break or whatever, and you can do 20 minutes, turn it off, come back, do more, whatever. And they are available to you. You're tracked. So we know when you've completed the course. There is a little thing that you fill out that you have completed it, some questions. And then you can get credit too for those. So if you want to get some CEUs for that training, it is available. It's free. Normally Relias charges, but the grant's picking up the cost, and we do have slots available. So if you would like to get some additional trainings, talk to Valerie. She can set you up, get you a password. You can go in, you can take a look at what's out there and take the classes. You can pick and choose what works for you.
And
So it's
then
a
also to mention, not only do we have those specifically designed for HCBS that are generalized, because we did want to make sure that those CEUs fell under that. There are an additional 400 and some odd, but we have well over 500 trainings on there that you can choose from. Maybe something that would benefit you personally, that might give you a little bit more encouragement as a DSP and the things that you do. So those are available to you.
good resource. All right. Well, thank you all, and we'll look forward to seeing some of you next week.